I'm just having a little study break, half an hour, and I thought, let's study what I'm studying. I'll answer some questions about mania. It's actually something I've gotten a lot of comments on in my comments section. So let's just get straight into it. No mucking about. Um, I'll just go through different comments and talk about them because there's some really interesting questions here. So the methods of this, I guess, experiment has just been to search my comments for any comments that include the word mania or manic, and I'll try and keep them de-identified. I guess comments are public, but anyway, keeps things simple. This comment says, when I get manic, people notice my eyes way more. I've been described as having big eyes and looking around everywhere and being really reactive to movements. When I'm depressed, it's the opposite. My eyes become lifeless, baggy, droopy. But even with mania, my eyes will have a dark ring around them because I likely get very little sleep. My eyes are naturally large, so when I feel manic, they become 10x more noticeable. Interesting. Yeah, you can tell a lot from someone based on their eyes. We when we do a mental state examination as psychiatry doctors or doctors working in psychiatry, we often describe the eye contact. But other, things that are important are the speed of blinking rate. So someone who has a kind of catatonia, where muscles are actually slowed down, their blinking might be really slow, and sometimes they don't even blink the whole way. They kind of only get halfway. Their movements might be really slow, and you'll feel it in yourself. You'll feel. You get this internal feeling when you talk to someone with slowed movements. Kind of like it makes you feel uncomfortable, makes you want to like say hurry up or something. But noticing that in yourself is how you know that there's something wrong, because you know something's not operating normally in them. Another interesting thing about eyes. Do you see mine? They're very white. Homo sapiens are one of the few creatures that have the white sclera around the eyes, and the evolutionary advantage of that is that we can, in a group, we can see where everyone is looking. If you think of gorillas and chimpanzees, it's all just black, their eyes, so it's hard to actually see where they're looking. So if someone, well, it increases our social communication, so it increases our survivability, and therefore is a good thing evolutionarily. So anyway, that's an interesting tidbit about eyes. Let's see what the rest of the comment says. Also, I don't know how she could feel mania feels great. Honestly, it's hard for me to notice my mania, but I feel when I feel awful. Usually I'm anxious and irritable when I'm manic. That's a really interesting insight. We'll talk about that in a sec. It doesn't feel good at all. People have told me I become egotistical, rude, and sometimes even overzealous about certain beliefs or values. I also tend to poke people and jab my friends with my fingers when manic. Not a lot of impulse control either. So we haven't actually spoken about what mania is in this video yet. Hopefully you've seen some of my other videos where I talk about it at length. The quick and dirty summary of mania, bipolar illness is a lifelong chronic illness that is characterized by episodes of depression and mania. Much more often it's episodes of depression, but it only takes one episode of mania and you get a bipolar diagnosis. Everyone's journey with bipolar is different. For some people it is debilitating and persistent and difficult to treat and difficult to contain. And for others, it can be very well managed and they can have, quote unquote, a normal life. It can be dangerous, right? Bipolar is something to take quite seriously. This isn't just stress and a bad day. This is serious episodes of, for example, in mania, it's days of almost no sleep and everything turned up. The speed of thought, the speed of thought is so quick it can be hard to express your thoughts in words. Your words can't keep up with your brain, and you're always on, but not on in a good way. You're making bad decisions, you're losing money, you're disinhibited. People cheat on their partners, people lose all their money on gambling. Their lives can get ruined in a manic episode. There's a sad quote, which is that manic episodes end up in jail, hospital, or worse. So, like, treat mania very seriously. But some people, I guess there's kind of, in terms of how people feel, two kind of types of mania. There's the kind of euphoric mania where people feel really good. They kind of look high. Sometimes they feel expansive and positive, and they're having all these great ideas. And then there's the irritable mania where things are going so quick in their head. How can you not keep up with me? What is wrong with you? Get out of my way. Get out of my way. I need to hit this goal. And, I'm getting whatever the goal is, taking over the world, being God, whatever it is. Now, from a psychiatric perspective, the most important distinction to make is whether there's psychosis or no psychosis. So that influences kind of some of the decisions we have to make in treatment as psychiatry doctors working in psychiatry. So she made a good point in her earlier comment around not sleeping, and I guess here she's described how she can get irritable when she's manic. So this is not a kind of euphoric manic picture. This is an irritability manic picture. I've also noticed that around people with ADHD or in manic psychotic episodes, I tend to bounce back the energy regardless of if I'm in a manic state. It's weird. It'll never feel like a full mania for me, but it's like their energy levels affect my own, and it's what's caused me to make poor decisions in the past because neither of us were in a healthy state of mind. But if I'm in a deep depression, it's harder to actually match the energy, and I've been called a downer because I tend to hold pessimistic and hopeless thoughts when I'm depressed. Luckily, I'm medicated. However, my dosages are seen as quite low compared to most with bipolar, to be honest. But that just means my brain is more sensitive to treatment and changes. Yeah, look, when it comes to treating bipolar and treating depression and mania, there's no one size fits all. Okay, like complex problems have complex solutions, and it's all personalized. So we need to titrate the medications to the patients. This is an interesting comment. What's the difference between a manic episode and someone being artistic? She seems very likable and creative. That's all. So that's a great question. There have been some very famous artists with bipolar illness, and it's hard to know historically with lack of medical records, and you don't want to be too sure about things when you're interpreting history. But it does seem that Vincent van Gogh was suffering from a bipolar illness because he had very distinct episodes of depression and very distinct episodes of what looks like mania, and people argue that you can see that in his work, in the colors and creativity of his works. So it's a question I ask sometimes, especially with people who are alexithymic. So alexithymia is when people struggle to find words to describe how they feel. It's very common, especially in like men in their 20s. So this is a good question to ask because sometimes I'm like, well, how's your mood been? And they go good or bad. I'm like, oh, tell me more. I need more. So a question I can sometimes use to get more out of someone is, well, if you were going to paint a picture, what would you paint and what colors would you use to represent your mood? And that gets them thinking. So anyway, that has resulted in some very interesting kind of responses. Another very common way to explore mood is by asking from 0 to 10, 0 being horrible, 10 being the best you've ever felt, 0 being the worst. What's your mood? And a lot of people with mania will say 12 or 100 out of 10. When I was manic, I thought I didn't need to sleep because I was actually Jesus Christ. I'm not even religious at all. It was all together with erotomania, which played out very badly. I'm so glad I sought treatment. With medication, I have been very stable for almost 3 years now. That's very good to hear. And that is a very good example of how risky mania can get. It's one thing to think of mania as just feeling great and being hyper productive and doing all these things, but the reality is not that. I think there's a problem I think society romanticizes what mania is in film, and I've seen it in a couple of TV shows where mania is like kind of seeing everything as colorful and dancy and exciting and positive. But if you think you're Jesus and you can walk on water and then you drown, or you think you can fly and you jump off a roof, or you have a erotomania and you think someone's in love with you and you stalk them, these are all things that can end up in very bad situations for everyone, right? It's a lose lose. I've had people love their mania and kind of come to me hypomanic and feel the mania coming on, and I'm, you know, tr- this is a pretty common thing. You're trying to treat the hypomania before it becomes a full fledged mania and bad things happen. But sometimes they don't want it, and that's their right. I respect your right to make a decision I don't agree with as a doctor working in psychiatry. So, uh, it, we only initiate involuntary treatment when the risks justify it. But that is a case by case assessment, and some people will just be manic and not medicated, and that's their right. Even if I personally don't think it's a good idea. Yeah, I think we've got to be clear on what the role of a psychiatrist is and how paternal mental health is. But there is absolutely a fundamentally and socially critically important role for, I guess, involuntary treatment of someone who is lost capacity and is at high risk of harm to self and others. Definitely. But there are people who don't meet that threshold, don't do what I would suggest, and that's okay. We can respectfully disagree. Interesting, the similarities between amphetamine use, high highs followed by low lows. Even more interesting would be to study amphetamine users who suffer from mania and bipolar. I'm curious about the connection because I used to know a user who suffered from episodes like this. Right? So, how do I know if someone has just used amphetamine if they're experiencing a manic episode or intoxication? Answer: I don't. I mean, I know they're intoxicated because I can do a UDS and see that there's amphetamine in the system, but I can't, just from observation and just talking to them, say that there's no manic component at all. So, when we diagnose something, we go in a hierarchy of diagnoses. We start with biological disorders. So, if they have an encephalitis, if their brain has an infection that's triggering the mania, I don't call that bipolar disorder. I call that an encephalitis. If they have a drug use, like amphetamine use disorder, and that's triggering a manic like illness, I'll call that an amphetamine intoxication, not a manic disorder. But if there's none of the above, and we're going down the hierarchy of going down the diagnostic hierarchy, if they do have just a major bipolar illness and they've had manic episodes before and they're having another one, I'll call it a manic. It has to meet the criteria, of course. But I guess all that to say that it's the key takeaway here is that it is very hard to detangle a diagnosis from someone who uses substances, particularly methamphetamine. So there are, I don't know, hundreds, maybe thousands of people in Australia that have diagnoses of, recurrent drug-induced psychosis, methamphetamine use, query schizophrenia, because we can't say it's schizophrenia. We haven't had that period of drug-free observation. But amphetamine use can, I hope you know, but obviously it can trigger psychosis, and it can trigger manic episodes. So it's hard to detangle what's what, and requires a lot of, I guess, detangling. I suffer from bipolar 1. My mania is much worse than the ones shown in the video. I have a report of the psychiatrist who saw me under and describes well how my mania was. My head would move up and down in uncontrollable giggling. I was like that for 8 months. Crack lots of funny jokes that made many people laugh. The consequences of it is that I had a huge mental fatigue. Interesting. So, I guess an important thing to say here is that mania, I mean, I think it's fair to say that mania is a toxic brain state. Like, it's not, the longer you are in mania, the worse it is for your brain, right? The lack of sleep, the hyperactivity of neurons, the toxins the neurons are producing and not getting cleared out. we don't have the fidelity in neuroimaging and science as a whole to demonstrate this very clearly, but we can see it based on kind of some imaging and atrophies of the brain, and we can make deductions from what we know from how neurons behave and how important sleep is. So I don't think that's a controversial statement. I think mania is bad for the brain. So yeah, huge mental fatigue. That's one way to put it for sure. And I think another interesting thing here was the giggling. So as a junior, well, I'm still junior, but when I started as a psychiatry registrar, so for those who don't know, I'm a doctor in training to become a psychiatrist. I am a doctor, but I'm just on a specialist training pathway. When I did start this kind of trajectory, and I saw people with euphoric mania, my gosh, it was delightful. I would laugh. I would, well, the term is, I would experience projective identification. I would identify with the emotions. I would feel expansive with someone who was expansive. If someone had all these quirky ideas, I'd be nodding along, And it didn't take long for me to kind of mature out of that, for the record. But what you have to realize is, a therapist or a treating clinician, is that this is, even if the person is feeling on top of the world and super happy, smiley and funny, this isn't funny. This is very serious, and it's a toxic brain state. And this isn't a kind of real euphoria. Well, it is real for them, but it's not a healthy one. So it's something that needs urgent treatment. So it also is bad. So it affects your objectivity as a clinician. You want to always try and remain as objective as possible. And when you are identifying, experiencing, and it's almost too empathetic. When you're too empathetic to the point where you lose objectivity and you're reacting too much, you lose objectivity. You're getting influenced too much by the social connection between you and the patient. And so there's that balance to hit where you don't kind of start giggling and joking around with someone because they're manic. That's a very important balance to hit. All right, we're 20 minutes in. I still got 10 more minutes to go. Let's keep going. If you guys haven't liked and subscribed, please do. Sorry, I have to remind myself to bring that up at least once in a video. I have to say that. It's how YouTube works, guys. Don't hate me. Hypomania feels amazing. That's been the biggest challenge in treatment of my bipolar disorder, because I get on meds during a depressive episode and then I feel better, so I stop. However, after having 2 very bad psychotic manic episodes, now I'm like, okay, let me stick to the meds. So far they're working really well, and now my issue is, how the F am I going to fix all the damage I did when I was manic? I have many apology visits to make. Interesting comment. Thank you for being so open with your comments, guys. It's really important for everyone to kind of hear this stuff. So first thing to say is, yep, it feels great to be hypomanic. The second you're psychotic, it's not hypomania anymore. That's a bipolar 1 illness. So, or schizoaffective disorder. So hypomania is this term. It's an interesting term. Not everyone is I don't really know how I feel about it. We don't call anything hypodepression. We have persistent depressive disorder, but that's different that relates to depression differently to how hypomania relates to mania. But I guess the term hypomania is when someone's elevated. They're a bit more intense, a bit more expansive, sleeping a little bit less, but they're still holding it together. They're still getting to work. They're not breaking up with their partners. They may be a little bit silly, but nothing life kind of changingly silly. And they're not psychotic, and they don't need hospitalization, right? That's an important distinguishing thing. And then mania is everything just turned up to the extreme. So hypomania, bipolar two disorder. That's the thing that distinguishes bipolar two from bipolar one. By the way, hypomania versus mania. So you can have the exact same depressive events, but if you've had one episode of hypomania and none of mania, we call that bipolar two. But it's important to think that, well, maybe this is a bipolar one that just hasn't yet had a manic episode, right? Because if you remember, most of the time in bipolar is spent depressed. And so people who have people who are diagnosed with a treatment resistant or difficult to treat depression, sometimes we give them bipolar medication because we're thinking, well, maybe this is a bipolar depression, but the person hasn't yet experienced their manic episode. And so we can augment depressive treatments with bipolar treatments. Yeah, interesting. Yeah, I'm glad the medications are working, and it will be tricky to fix all that. I really would have appreciated a mention of mixed episodes in bipolar disorder. In my experience, these states are the most dangerous. You have all the depression, hopelessness, and pain of depression while also experiencing the irritability, anxiety, and impulsivity of the mania. This type of episode is mentioned so much less frequently than depression, mania, or hypomania. I've met people who have been diagnosed with bipolar for 5 years who have no idea what a mixed episode is. I don't know about what statistics show, but these states have always been my most dangerous times personally. 3 attempts on my life have all come from mixed episodes and never from just mania or depression alone. Well, that's a very uh, true reflection. Agitated depression or a mixed episode state is a high risk situation, and it lowers my threshold for hospitalization considerably. So if someone is depressed, they're suicidal, but they can't stop talking, they're hyperactive, they're agitated, they're writhing, they're kind of going left to right, not in an akathisia way, but which is a side effect from medication, but in a way that's like, I need to get out of my body. I need to stop this horrible feeling inside of me. And it's almost like they're trying to, escape their body. And the the lack of sleep and the impulsivity and the disinhibition, as this comment describes, of mania, makes all the kind of risk of depression much more real. One of the actual kind of things in the severe psychomotor slowed depression is that they might feel suicidal, but they don't have the energy to do anything. Like, it's almost protective. They can't even get out of bed to organize a attempt on their life. So that's I wouldn't consider that a protective factor, but that is a barrier to them uh, acting on that impulse. It still probably needs hospitalizations for the record, but everything's a case by case basis. Anyway, so when you have a mixed state and you have all the energy, but all the depressive cognitions. So when I say depressive cognitions, I mean um, essentially, all the things that you think of with depression: the hopelessness, the helplessness, the catastrophization, the fatigue, and the suicidal ideation. Yeah, so all that can be very tricky. So yeah, I agree with this comment, and it is a very high risk thing. It's less common, I guess. That's why it's not talked about very often. I've seen it maybe four times in the last year or so. But when you do see it, your alarm bells have to go up. I have borderline with mania and experience anxiety, depression, and ADHD. Makes sleep at night very difficult. Well, that is a bad cocktail. Yeah, it's a very tricky situation to have that kind of cluster of diagnoses. When people have this set of diagnoses, the kind of bipolar, borderline, complex PTSD, ADHD, depression, anxiety, it's really, it's not that they have 7 different illnesses. It's one thing in the brain, and we as doctors and scientists just haven't found the right we just don't have the right neuroimaging and diagnostic modalities to tell you the exact thing. So what we're doing is using multiple observations of behavior to give a list of diagnoses that characterize the experience you're going through, which allows us to do research on it, etc. These situations just kind of highlight the limits of our diagnostic accuracy in psychiatry. But this cluster of, I don't know at all what's happening in this person's life, but what I do see with this cluster is that it's often from a traumatic background with either neglect or trauma in childhood. And when you have kind of issues in attachment and security as a child, if you don't have a secure relationship as a child or a secure home, or you were neglected, all the next stages of development get affected by that. So it's very hard for you to be a calm, to fall asleep at night. You need to have a certain level of trust in the world that you're not going to get hurt. But if that's what happened to you when you're a kid, you have to, who's going to teach you that, right? You need to learn that through therapy, I guess. And so whenever someone has a kind of bipolar and a borderline dual diagnosis, it's really important that they get treated for both. So the borderline stuff needs either DBT, schema therapy, mentalization, whatever you want. It needs like good therapist rapport, security, safety. When the highest thing that will predict whether therapy will work is your rapport with the therapist, and that comes from having that safety, that safe environment where this person is on your side, but also will set boundaries from a place of care. It's not and boundaries are important. So yeah, I wish this person all the best, but it's a very tricky dual diagnosis. And I've had people, with personality vulnerabilities say I'm manic, and but they, sometimes it's not mania and it's emotional dysregulation or something, and we just give it a bit of time. We don't overdiagnose too quickly and don't over medicate too quickly, and I guess it's always a case by case scenario, so I can't speak too generally on that. But yeah, it's tricky when people have dual diagnoses. Certainly something I wish to get better at and help people with more. And that's it, guys. Oh, I forgot to leave love hearts for all of these comments, but I will. I'll go through them and leave lots of love hearts because I really appreciate people commenting and sharing their experience. I appreciate people agreeing with me, but I also appreciate people disagreeing with me. I'm learning. I'm on the psychiatry training pathway. I'm not a psychiatrist yet, so give me all the feedback. Let me, it's all about lifelong learning in this field, and things are going to change quick. Anyway. Toodaloo, that's it for me, and I've got to get back into studying, and I'll see you all in the next video. All right, bye for now.